So today we're going to talk about otoscopy, and probably the most important thing to know about otoscopy is that because of how taking pictures work and blocking works, you will almost never find a really good picture of otoscopy being done. Take this for instance. There's no bracing, it's at a weird angle. The man is looking through the viewfinder while approaching, so he can't see like where the ear is. He has no depth perception. So you will very rarely find a good one. So that is a no. There are a bunch of different types of otoscopes to be aware of, though. Probably the most common one is the Welsh Allen silver-handled, black head, kind of heavy, full-sized one. Macro View might be starting to eclipse it. They're kind of pricey, but they're really rather nice. Lamar's clinic has both of those full-size types for you to work with, so you'll get to experience them both. Pocket-sized, you may encounter occasionally. They're not very sturdy or very bright though, so they're not necessarily the best option. Battery powered versus wall mount. Physicians' offices tend to go with wall mount. I don't see too many audiology offices that do it that way. Open head versus closed head. Mostly in audiology, you'll be seeing closed head ones. Open head is for performing procedures through. Video otoscopes are really kind of nice because then the patient can see what you want to see. And then there's the fun little iPhone otoscope, which the Lamar Student Academy of Audiology actually has one. I'm not entirely sure if it's compatible with the newer iPhone, so y'all will have to check it out in the bag. Of the battery types, you've got alkaline ones like the standard disposable, maybe rechargeable ones that you have at your house. Mostly that's the pocket-sized ones. There's lithium ion, which they retain their charge very well even when it's not in use. They remain charged even when they're not on the charger and they're just sitting there dead. And they're quite a bit lighter. NiCads are probably the least desirable ones. They're low charging capacity. They're very heavy. They don't last as long. Nickel used to be the most common one. It was kind of a nice middle of the road option so that you could, balance cost and features. Lithium at this point in time is starting to eclipse everything, but otoscopes last for a really long time. So if an office has had some of the other kind for a while, they're going to keep them. People don't just upgrade otoscopes because they can. So here are some of those examples of the different heads I was telling you about. This is the most common older sized one. The SAA, Student Academy of Audiology bag, has some of those in there. And if you look, this lens right here actually slides out so you can clean it. This is the open head one, and this particular one, it flips around the hinge. It may or may not have a magnifier in here to look through. This is the macro view, and it's nice because as you see here, it has an adjustable focus. The other thing to note about this and to pay attention to, especially in the time of COVID, is this little collar actually spins. So what you do is you hold the whole head over the trash can and just turn that, and it'll pop the specula off and right into the trash. This is the same macro view, except it is the video type. So you can see there's no lens here like there's a lens here, but the adjustable focus is the same. The only thing I don't care for with this particular one is that because there's not an accelerometer, you have to hold it upright, or you have to kind of guess, okay, what angle am I holding this? What angle? And to count the landmarks that you're looking at. Now let's talk about light sources and light bulbs. Incandescent ones are pretty cheap. They have a short lifespan and they are dim, 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 dim. Hard to see things in the dark with a dim light. Halogen ones, they have a longer life and a brighter glow. Xenon ones are even longer lasting than that and burn brighter, and LED are the longest lasting and brightest, but they have a whitish blue color that some people just don't think is very good for diagnostic purposes. The majority, probably still at this point in time, is halogen or xenon, but LED is starting to eclipse it, and the otoscopes that we use in the clinic are LED for the most part. So what does it cost? Well, the mom style, the cheap pen style ones are about $40. You can get a nicer pen one for about $100. The full-sized heads, the one that I was telling you about earlier that you could pull the lens off and wash it, is about $100. A full-sized one, the Welsh Allen one, with the battery source. Let me learn to talk today. My apologies. The full-size head of the older version of the Welsh Allen's about $100, and the battery and the handle is about $150. So your potential full-size total cost ranges from about $250 to $800. The macro view is with the lithium ion handle is definitely on the more expensive end of things. If you decided you do not have to buy yourself your own otoscope right now, but if you decided you wanted to, please do get in touch with me and see what kind of discounts I can help you find, and go ahead and alert your families the same to don't just buy you something, because lots of parents decide to do for Christmas that first year, and so it varies wildly. There's lots of discounts out there if you know where to look, though. So what kind of features are we looking for in an otoscope? Well, the standard ones have a little bit of magnifying. They have 8 diopters. Diopters are the power of the lens. It's how much it magnifies. The macro view one, though, is considered panoptic, and it actually goes from -20 to +20, and if you're not so great with the vision like I am, it's definitely the more pleasant one to work with. It kind of lets you not have to do so much moving around to see better, but do spend time with both types of otoscope. Another thing to think about when you're looking at an otoscope is what kind of speculum it has. Some of them you can use disposables with, some of them you can only use reusable ones with. They might have only 2 different sizes, they might have 4 different sizes. You tend to have more sizes of the reusable ones, and the disposable ones usually come in just a pediatric size or an adult size. So now what are we going to do with these fancy battery-powered lights that we wander through life with? Well, we're going to examine the ear. And to do this, I want you to remember to hop. Now, in the video, you can't see my whole shtick, and so normally what I do is I'd bunny hop around to remind you: history, observation, palpitation, hop, hop, hop. So imagine my full-sizeness hopping around the room. Picture that. Okay, got it in your head? Hop, hop, hop. History, observation, and palpitation. So let's talk about that more. What do we mean by history? We are looking to match what the patient is telling us to what we are physically seeing or not seeing. So by this, we're talking about potentially trauma. If they said they had a head injury, we're looking for maybe blood from recently. If they're telling us they have allergies and colds or sinus drainage, we're looking for retraction of the tympanic membrane or fluid in the middle ear space or bubbles, that sort of thing. If they're telling us that there was changes in pressure from flying or diving, maybe we're looking for a perforation, a hole in the eardrum. We're looking for them to say they have dizziness. Well, it's a very different thing to see something abnormal in the middle ear and have dizziness versus, not seeing anything abnormal in the outer and middle ear. We're kind of trying to look for, if they say they have changes in hearing, we're trying to look to see if there's anything in the anatomy that we can physically see that would be impacting it. And of course, always, always, always the duration of symptoms. The time domain is so, so, so important. Everything about case history and progression of disease has to do with the time domain. Noise-induced hearing loss, it depends on how regularly and how long they were exposed. Cholesteatoma, how many ear infections, how long has it been growing? Acoustic neuroma, obviously, how long has it been growing? Everything about audiology has a time domain that you need to look into and consider. So, observation. What are we looking for? We're looking for abnormal coloration. Remember when I was saying about the LED light bulbs being so blue-white and people not liking it? Well, red and blue kind of want to cancel each other out, so that so that's why people don't necessarily like to. Okay, my apologies. Don't aspirate your own spit. That's going to go poorly for you. So the bluish white light can kind of cancel out some of the redness. So that's why people don't like to use them, especially if that's not how they were trained. If you were trained on them, though, you just kind of get used to it. Another thing we're looking for is swelling of the pinna, around the pinna, all of that. Drainage, of course, foreign objects, especially if you're planning to stick something into somebody's ear, you really, really need to look to make sure there's not something there in the first place. You also want to notice any cuts, any scrapes, any bruises, anything that's going to cause the patient discomfort that you're not expecting. And then, of course, deformities. And when we're talking about deformities, we're looking for both congenital and acquired ones. So you might see some skin tags on there. You might see a little pit here. See the little pit there? We've got a skin tag there, a pit there. Here is a very big example of mastoiditis. You don't normally see it quite that big. And there's a perichondral hematoma. Now, I'm going to sound a little bit brain dead, but my camera is covering that up, and I don't remember what that is. But definitely, if you see something like that, ask your supervisor. So another thing that we can look for, or we need to look for, and it goes back to the if something's already in there, you don't want to push something else in there, and that's excess cerumen. So audiologist is Medicare. Let me start with Medicare is the insurance for elderly people. Who are most of our patients, unless we're pediatric audiologists? They're Medicare recipients. So a lot of times when I say something, it's going to mostly apply to Medicare. But also note, if other insurers don't have a policy of their own, they tend to default to what Medicare does and doesn't cover, and to who Medicare covers and don't as far as providers. So when I say we can't bill but we can get paid, that's mostly Medicare. You might have a contract with Blue Cross Blue Shield or Cigna or somebody else that will cover it, but mostly we're working with the elderly, and mostly they have Medicare as their primary, and they definitely don't pay audiologists for cerumen management. So all that to say, Medicare won't pay for it, but just because Medicare won't pay for it doesn't mean that we can't get paid to do it. We just have to charge the patient. So let's think about how we talk about cerumen. First, cerumen occlusion versus cerumen impaction. Cerumen occlusion, you think in percentages, and then you kind of equate it to, like, similarly to the hearing descriptors. You have minimal cerumen occlusion, mild cerumen occlusion, moderate cerumen occlusion, and severe cerumen occlusion. So it's about what percentage of the canal and tympanic membrane structure is being occluded or blocked from being seen. Now, cerumen impaction, Medicare defines it as a significant obstruction of the canal, cerumen that impairs the examination of clinically significant portions of the external auditory canal, the tympanic membrane, or middle ear condition. It needs to have bothersome symptoms, and it has to be like extremely hard or dry or irritative that causes pain, itching, or hearing loss. It could have inflammation, and it has to have difficult removal that requires tools to do it, and it requires the quote-unquote physician skills. The CPT codes are the billing codes. 6209 is removal of impacted cerumen using irrigation or lavage, unilateral in one ear. And 69210 is the removal of impacted cerumen requiring instrumentation unilaterally. Now, again, Medicare doesn't pay for this, but it is worth looking up to see, back up. Medicare doesn't pay an audiologist to do this, but it is worth looking up to see what a physician would get paid to kind of as a starting place for setting your own price. Now, Medicare rates very often don't exactly pay the bills, but you kind of have to think, if I sent this patient to their physician, how much would they be out of pocket for that? So you kind of got to assess it. Now, ICD-10 codes, on the other hand, those are diagnosis codes. And so those are how we tell insurance companies why we had to do the procedure codes. So CPT codes are billing procedure codes, and ICD-10 codes are billing diagnosis codes. So there's different codes, and they can be quite specific, and when there's a specific code, you want to drill down to be as specific as you can. It's more likely to not get you in trouble. Now, palpitation. So that is a gentle pressure on the tragus, and you don't have to like quite so obviously press like this, one hand doing anything else. I'm going to very awkwardly take off my headphones so I can kind of show you something. So when you are doing otoscopy, you kind of can like open the ear up and do it at the same time. I mean, if you wanted to and were comfortable just palpating around, but a lot of people aren't. So I did want to point out that when you're opening the ear to do otoscopy, that is actually an option to count for it. And then traction, like you saw me reaching up and around, that's part of that whole palpation, traction on the earlobe and pinna, so you can kind of move things around. And basically what you're looking for is how does it move, if it moves, what temperature it is, that sort of thing. And also for later in the process, having an idea of how stiff or soft it is can make your choices for what kind of transducer you're going to use. If it's very, very stiff, and you can't straighten the canal out, then inserts might not be a good option because you might not be able to get deep enough. On the other hand, if it's very, very soft, headphones might be a terrible option because it'll collapse the canals. And we'll talk more about that when we get to the pure tone section. So let's talk about infection control for a minute here. There is perfect best practice and there is real world. Perfect best practice says you should never stick something in one ear that you've then stuck in another ear. That you then stick in another ear. Sorry for my tenses. Because what if there is a contaminant or an infectious material in the first ear and then you've just transferred it to a healthy non-involved ear? So that's perfect, like best case. Reality is, if you've ever been to a doctor, I have literally never had them use a different specula between the two ears. So if you aren't going to use a different speculum, you need to evaluate the non-involved ear first and then the involved ear or the complaint ear. And this provides a basis of comparison. You want to kind of see what's normal for them, but also it's to help prevent cross-contamination. Now, if you do that quote-unquote non-involved ear, because I say non-involved here, and you look and it looks like it's got a fungal infection, drainage, anything out of the ordinary, definitely do not cross-contaminate. Throw that speculum away and do the other ear first. The other ear with a fresh speculum. They're not that expensive to just be potentially giving people another infection if you don't need to. Wait. You should never give your patient an infection. That's a bad plan all around. Don't do it, all right? Be mindful of infection control so that you don't cause an infection, because that's on you and your license. So, step 1, place your patient in a seated position with their head either upright or slightly tilted over, not as much as I just did, just a little bit, so that it makes it easier for you to access it. You want the ear that you're looking at to be slightly up or very perpendicular rather. Then you want to select the largest possible speculum that could be comfortably inserted in their ears. In general, children use ped specs, which are more about this size here, and adults use adult specs. They're like 2.75 and 4.25, I think is what the common sizes are. But people will surprise you. So look at their ear before you just go sticking something in there. Because for me, I have to have a PD spec, and I am not a small person, but my ears, much like my little hands, are small. So why do you think you need to use the largest possible speculum though? Notice the shape. See how it's kind of angled like this? Look at my beautiful drawing. So if you use too small of one, it's going to go too deep in their ear and you're going to bump into their canal and it's going to be very uncomfortable. And you would think that the bigger one is going to be the more uncomfortable one, but it's really not, because most people's ear canal is pretty much the same diameter throughout. Like that, it's going to be the same diameter. So when you stick a speculum in, and it's shaped a bit like this, you go all the way in, and so the bigger spot here, it stops on the start of the canal, and then since this is angled, this part is much less likely to actually touch their canal. And if the pointy, scrapey part here is not touching the canal, it's going to be more comfortable. Oh, my apologies. I meant to fix that. That should say step 2. So when it's inserted, it needs to fit snugly in the outer third of the canal, and it rests against the tragus. and the anterior wall of the canal. And I'm saying it doesn't even just rest. You literally are pushing the tragus forward to straighten out the space. Use the specula to push the tragus forward. And when you're initially putting it in, part of that palpation is to take that tragus and pull it forward. You want to pull the tragus forward to give the space for this to come in. And like I was telling you guys earlier, if it can go far in and there's a lot of space around the specula, it's going to move, and that's going to be a great big ouch right there. Now, the best practice is to hold the otoscope with the same hand as the ear you're examining. So to use the right ear with the right hand, the left ear to the left hand. There's actually two different ways. That's like the textbook correct way, but not everybody has good fine motor control with their non-dominant hand. So you'll be learning how to do both the switch hand and the double bracing of cross hand. And part of your lab is to try them both and to tell me which hand you prefer on the non-dominant side, and also what your dominant eye is. And it should be stabilized by placing a ring and the little finger on the patient's cheek or the temple or something like this to hold it. As you'll see in the lab though, we'll do a little bit of practicing. You'll put an otoscope in somebody's ear and brace, and they'll move your head. But just watching my hand, if I'm moving, see how the pen, well, that wasn't a great choice. I have a red pen and a red wall, and that's not great. But you can do it yourself and see, like stick your pen in here in the middle like that and move and see if you stab yourself in the face. You want to have enough in here and keep everything stiff enough that if they move, especially children, that you're not going to stab them with the specula. And kids especially, when you go to look in their ear, they know you're there, and their instinct is to look to see what you're doing over there. And I'm sorry if me bouncing made a really loud noise. So this is pen grip, and it's basically, I mean, think about how you hold a pen, right? It sits comfortably in here. You want it to sit right here in the webbing so that the weight of the battery is nicely balanced here. And then you have fine motor control at the tip. Hammer grip, I'm not as much of a fan of that. Just not. I think if you come at it with an awkward angle, it makes the specula point a little too far down. You're more likely to scrape their canal. But if you're using a video otoscope that doesn't have an accelerometer in it, you have to hold it this way, otherwise it's going to be at a weird angle. So battery powered ones though, I expect you to do it this way. Now let's talk about straightening the canal. That specula is straight. It's not flexible, it's not curvy, the specula is straight. So you just need to get the ear canal straightened out as much as possible so that you can actually get it in there. But also, we're trying to see the eardrum down at the bottom of that ear canal. And much like when you're driving on a hilly road, if you're at a bad angle, you can't see what's further down the road, right? But a straight road, you can see quite a ways down. So if we don't straighten it out, we won't see all the landmarks. Now, if somebody's ear is super stiff, you might not be able to. You just have to do the best you can. Now, most adults, when you're straightening their ear canal, it's kind of up and back and out. Kids tend to be more straight back or even potentially down, but it's out a little bit. Don't like pin it close to the head. So one more, take this off and be awkward with it. So when you are doing this, you can see where it is on your ear. See, for me, if I pull it this way, it actually closes my ear up. So the way you can test on yourself is take a finger, put it in your ear. I know this is goofy. And then pull in different directions and see which opens it up the most. And you can see which direction opens up the most for you. Now for a patient, when you're going to, that's part of the whole palpate thing. Try in different places. Try holding it at the top of the pinna. Try slightly back. Try kind of in the middle. Try a couple of different places and try a couple of different angles while you're shining the light in there. And you will see the ear canal hole. You'll see it open up. You just do. You're just pulling up with an ear and like shining a light in it so you can see. So you need to straighten the ear canal prior to inserting the speculum. You need to be looking out at it, not through the otoscope. You're using the otoscope as a light and looking at it while you're doing this. And again, adults most often up and back, slightly out, and children horizontally or down near the antitragus. Now, while maintaining traction in the same place that you'd already decided, don't loosen up, keeping the light shined in and your eyes a little bit out so you can see, you place the otoscope specula at, but kind of not in the ear canal to start with, and make sure you're kind of lined up. And you don't want to insert the otoscope blindly. Do not be looking in like that. Watch your way in. And so when you are looking at it, you've straightened it up, and you're going to see as it goes in the light shining around here. And while the light's shining around it, you kind of measure, is it even amount of light around the edges? And you keep going in until basically the light stops shining. You've blocked it all the way up. So you've had the slightest bigger part at the opening of the canal and it's plugged it up. At that point in time, you can move in and put your eye like that. So the components of not going in blind are to be parallel so that you can see the ear canal and see all the way around the speculum. You can change the height of your chair if you're sitting. You can squat if needed. You can kind of bend down and line your body up, but you want their ear at your eye level. And if you bending over, if you do forward like this and you're looking down, that's a problem. That's why I say squat for the most part. But if they're sitting, you can even kneel, especially if it's a kid, so that you can see and everything's kind of lined up straight. And then you move the tragus, like I said, with the specula tip so you can see the whole ear canal and it's open as possible. And then you're inserting the tip deep enough so that the light disappears and you see the specula fill the ear canal. Again, without your eyes being in the depth in the viewfinder. That way you know that you've got good insertion depth and you're not causing the patient discomfort. Also, it's a lot easier to keep holding traction like that if you're out here. When you're closing in, that's like a very common thing for people when they when they move their head in towards the otoscope, that they drop their hand. So if the patient experiences pain, you can reposition the canal by adjusting the angle and the degree of traction on the pinna. But if you're doing any adjustments, you're holding that in there and your eye was up there, pull your head back, look to see what you're doing, and then make an adjustment. Now, if the patient's discomfort persists, even after readjustment of the canal, you need to stop. Refer the patient out if need be. If there's something causing them that much pain that they can't let you look in their ear, that is something that's probably beyond what we need to be worrying about. Now, once you're in there, you need to kind of tilt and turn. Remember, the tip of the specula is narrower than the ear canal purposefully, which means you're not likely to see the entire tympanic membrane through there. So you need to kind of rotate or move so you can see all of the edges around the tympanic membrane to see the whole thing, because you want to see the posterior superior, the anterior superior, the anterior inferior, and the posterior inferior, all the different parts. Now, how do you know which one is which? Well, we'll talk about that in a little bit. How do you focus though? What if it's blurry? What if it's too far away? Well, for the macro view, you just use that little twisty thing that I was showing you about and adjust it. And it just focuses it for you. For the ones that don't have that, you've got to kind of try and go in a little bit deeper. So you may need to straighten the ear canal further, change the grip of the auricle, pull at a different angle to get in a little deeper, or pull back if you must. It's kind of like trying to view the corners of a room through the keyhole. There's only so much you're going to see sometimes. And particularly the posterior, the back, and the inferior, the bottom, is often difficult to see. It's due to the angle of the eardrum down there, and also it's at the bottom of the hill in the bony portion of the canal. And the bony portion of the canal is, well, it's bone. You're not going to straighten that out. Now, what are you looking for once you do see the tympanic membrane? You're looking for color, you're looking for clarity, and you're looking for position. It should be like a pearly gray color, very translucent, semi-transparent. It shouldn't be bulging and it shouldn't be retracted. Now remember, you're looking through one eye, which means you don't have any depth perception. So how are you supposed to know if it is retracted or bulging? Well, for one thing, you can tell by how the skin looks over the manubrium of the malleus. And yes, the tympanic membrane is skin. That's what it is. But if it's pulled tight and like shrink wrapped against the manubrium of the malleus, well, then it's probably pretty retracted. Another way to look is the size and shape of the cone of light. So the tympanic membrane is supposed to be slightly concave, which means you should have a kind of this direction. You should have a kind of tight beam for the cone of light. It should be pretty, like, I don't know, like a 20-degree angle-ish sort of thing. And it should be pointing towards, like, in the same angle as a person's jaw. If it is more diffuse and wide out, that's probably bulging. If it's very, very narrow, then it's probably retracted. And that's just light reflection. So what other key parts? Well, we're looking for especially the manubrium of the malleus. We're looking for the cone of light. We're looking for the, I can't pronounce it, annulus, the ring all around there. Those are pretty important parts. Then you want to be in the pars flaccida. You want to make sure you're looking there. And you want to look at the umbo, that tip that's attached to the manubrium of the malleus. And definitely cone of light. Very important. Note, though, that the manubrium of angles towards 5 p.m. in the left ear and 7 p.m. in the right ear. Can you picture that? So if you're looking to your left, you're looking into a right ear, 12, 1, 2, 3, 4, 5. So it needs to be pointing again kind of towards the jaw. And I think I just said that backwards. So not used to doing this in front. But yeah, the manubrium of the malleus as opposed to the conolite is the one that goes towards the jaw. The pars flaccida is this top part above it. The pars tensa is the stiff part where you have the reflection, the cone of light. So you're looking for any abnormalities, and you're asking yourself, well, how do I know what's normal and abnormal? Well, one, you just look in a bunch of ears all the time. But two, if you've got somebody else around, it's always okay to ask somebody. And three, an alarming number of doctors are really bad at otoscopy. There's research studies. You don't have to believe me. I can pull up the references, but an amazing number of physicians are terrible at it. At some point in time, maybe when the pandemic's over, maybe when I can get somebody to take a picture, I'll pull mine up on video otoscopy so we can take an image or look at it. I have scar tissue and they're always wanting to say it's bubbles. So I go to the doctor and get told a lot, oh, you have fluid in your middle ear. Let's give you these antibiotics. And I'm like, nah, here's my tympanometry. I have no fluid. I would know. And I get people who they've been seen and they said, oh yeah, it was clear. And I'm looking at a fully impacted ear or a dome in there or cotton. You can ask any audiology parent about their kid and ear infections, both directions. Either, oh, looks fine when they can see that it's green and pussy. Remember, pussy's not a word except in verbalization. Don't write that. You're looking for purulent. So maybe they saw purulent drainage and they're like, oh, no, it's clear, it's fine. And they're like, no, it's not. Or they say, oh, it's full of fluid, and they've looked and A, there's not, and B, they did tympanometry. So they're not. So I don't know exactly where I'm going with it, but practice so you can be good at it, because few things are a worse look than completely missing the mark. And if you are not seeing it, ask your supervisor. That's what we're for. We're here to help you learn to do this. So here we have some air bubbles. Here, like I was saying, here we have a perforation. There's a hole in the eardrum. Depending on what you see will influence a lot of the things that you do. If you see some cerumen, you may not use inserts maybe. If you see a hole in the eardrum, it may prompt you to do tympanometry. Otoscopy and case history are the first steps to deciding what you're going to do next and why. So work with us here. Practice, practice, practice. Look in as many ears as you can to become comfortable with normal. And since we're in the middle of a pandemic and I really want you to limit the number of people that you get this close, because you have to be this close, really, really close to do otoscopy, look at a bunch of pictures too. There's an otoscopy atlas. There's a lot of great images. There's wonderful websites and resources. You can look in the audiology Facebook groups, because people love to show their fun and interesting ones. Pictures are a good start, if nothing else. So, disorders, focus on the anatomy. And I have no clue why the disorders aren't showing up. So think about cholesteatoma. What are you going to see? So that's what I need you to do right now. Look up and find a picture of what your disorder would be. Let me stop stumbling over my words. Think about the anatomy of your disorder. If you are a cholesteatoma, where is the anatomy? Where's the problem? Where is this growth growing? So look up to see exactly what your disorder is, cholesteatoma or otosclerosis or the fistula, which is a superior semicircular canal dehiscence that you're doing, or noise-induced hearing loss, Aren't you glad there's computers and you don't have to try and read my typewritten stuff, my handwritten stuff too much? And acoustic neuroma. Where is the problem anatomy? Okay, did you look your stuff up? So cholesteatoma is in the middle ear space, right? Can you see that from otoscopy? Yes. Otosclerosis? Maybe. Look up some percentages and timelines for that. Superior semicircular canal dehiscence, where's that? That's in the otic capsule. Can you see that? Not so much. What about noise-induced hearing loss? Where is that happening? It's cochlear hair cells for the most part. So, but this depends, and it's time and event specific. What is causing the noise-induced hearing loss? If it's your standard long-term semi-high amount, you probably won't see that. That's cochlear hair cells. But if it is, say, explosive blast or blast trauma, you might have a perforation. You might have head injury. So maybe you would see something. And acoustic neuroma is the auditory nerve. Can you see that through otoscopy? So what I want you to do is to discuss in your disorders chat channel whether or not you can, like, what your disordered anatomy is. Can you see it through otoscopy? And if there's something to see, I want y'all to pull some pictures. So you can use the Otoscopy Atlas or Bollinger's, or there's a number of books. You can find some online. So post the discussion of what the anatomy is in your disorder chat channel, some images, and some references about what otoscopy would look like for the disorder. Okay? Oh, I apparently had screen transitions. My bad. That is terribly embarrassing. How did I miss screen transitions? Very sorry about that. And then if your disorder is something that requires a treatment, a surgery, I need you to do that for both pre-treatment and post-treatment. What would it look like? So cholesteatoma, do you have to have surgery for that? Most emphatically so. You do not leave that to grow. Otosclerosis, that's up to the patient, but that is something that you would have treatment potentially for, surgical treatment. Superior semicircular canal dehiscences can have a surgical treatment. So pre and post, if you think you can see something. Can you see something? And then noise-induced hearing loss, that's not going to have a surgical treatment most of the time unless it's blast trauma. And acoustic neuromas, what does otoscopy look like after treatment for that? So those are the things I want you to focus on in the chat channel for your disorders. And again, like I was telling some of you guys, I would get together as a group and standardize how you were going to tag things or note them, like is it disorder and then topic, or topic and disorder, so that when you use the search to find these things to help each other out, it's going to be easier to find. Additionally, if you pull a picture, I need you to, and it's probably going to be from a book, you need to print to PDF or print to image, label it as closely as possible with the APA format, and put it in the file section of your chat channel. All right, so this PowerPoint only took, I think, 50 minutes. The class is supposed to be an hour and 20 or so, so that gives you a good solid 30 dedicated minutes to find these images and information for your disorder that I am requesting you to do. So happy trucking, and if you were having trouble finding some of this stuff, please let me know and I will help you. Let your clinical supervisor know and we will help you.